starting. Hello, everybody. I think and I hope that you got fresh coffee to gather a little bit more intellectual strength to meet Emiliano Albanese, who is joining us from the south of Switzerland. He's full professor of public health at the university in Ticino, and he's the director of the WHO Collaborating Center for Mental Health Research and Training in the Faculty of Medicine, University of Geneva. He will be talking about interesting, important topics. Please be attentive and pose your questions either online or afterwards. Emiliano, the stage is yours. He will be talking about interesting, important topics.
Okay, so I think I have a little bit of echo in here. I hope it's gonna go fine. Can you confirm, Bogdan, that you can see my first slide? Good. Okay. Thank you very much, and thank you very much for inviting me over and for organizing this amazing conference. And I think this platform is really nice, so interactions are working very smoothly. And I hope that my presentation is going to be clear, but one it seems is going to be such. Okay, so what we're going to be talking about is what we mean by a dementia. We'll focus among diseases on dementia, of course, comprising several diseases. And I say WHO compliant with the program, as you will see in a moment. I will make explicit reference to the World Health Organization action plan on a public health approach to dementia itself, to which our collaborating center contributed. So first of all, this is a little bit pedagogical. Let me just remind you what we mean by a public health approach. So these are the elements that we have seen also from Muriel earlier on this morning. So we start off with epidemiology, and what epidemiology does at its best, the descriptive part and the understanding part, the analytical part to understand the determinants, risk, and protective factors. And we use this information to inform the design of a policy in a participative manner. And a policy, we'll come to this in a moment, well, it's a thin document if it's well written, but it's very, very important to give us direction. Now, once the policy exists, which is our case in dementia, of course, we have to overcome the first barriers to its implementation. The main one, we call it, of course, raising the awareness about the disease or the group of diseases, what we are addressing, and also the awareness about what we know, which we may call evidence or knowledge or understanding. And we do this inviting and involving actively all the relevant stakeholders and the general public in the process. This enables us to start planning our actions. And because we do public health, we focus from Miguel a lot on health promotion in the first place, so favoring the preconditions to knowledge exposed to risk factors and favor protective factors, and then decline it across the three main one, primary, secondary, and tertiary, as you know. This is also done in parallel with the implementation part, that is the design and evaluation, and of course a scale up of interventions, which may be complex or simple, and of course of services that can deliver this intervention over time. We keep, of course, measuring what we do and reporting on it, and we have the responsibility as part of public health professionals, as everybody else in the scientific community, to not just synthesize and put together this knowledge, but also to critically appraise what we get to know little by little, so that we refine our understanding. That's the evidence that we use essentially to make the effort. It was mentioned in a discussion before, the effort of translating all this evidence and all we accumulate and improvements in our knowledge into, well, clinical activities, practices, and of course, policies and practical aspects. So the translational bit, which is a bit complicated, is not just the typical bench to bedside, of course, and in the context of public health encompasses several levels of translation. Okay, so what did epidemiology do? Very quickly, we started off with Alois Alzheimer saying that it was, primarily is disease, primarily a rare disease of midlife, which seemed to be the case, with a case report, a couple of cases, and then the first epidemiological study descriptive to essentially demonstrate or find out, quite surprisingly, that dementia was in fact a common disease of older adults. We had to wait almost 60 years. It was conducted, as you know, in Northern United Kingdom. Now, in the past years, I know you know this, you know these figures, it's been used extensively. We took care of measuring the magnitude of dementias all over the world. We efforts from several investigators all around the world, and essentially to provide prevalence. So how many people have the disease? And we also calculated projections based on essentially the demographic changes that are expected in the coming years. And as you know, there will be an uneven steep increases in low and middle income countries because of the demographic changes expected there. Another key element of this creative epidemiology is, of course, attached to this dimension, the burden. So how impactful is dementia? You see here one figure that we published in the Lancet now 10 years ago about the fact that the population attributable fraction, so how much dementia explained the disability in older adults, is up to 25%. So dementia is not just common as a disease, but it's also highly important so on patients and their family and caregivers. In terms of understanding risk and protective factors, Alzheimer's Disease International entrusted us to write a report in 2014. We now know that this has been updated, and the Lancet made a fantastic effort, and Jill Livingston led this effort and put them together. There are good models, and most of these evidence comes primarily from observational studies, cohort studies, very long follow-ups that allowed us to determine associations, and we hope that some of these at least are not much biased or confounded. Some risk factors are shared with other non-communicable diseases, primarily, of course, cardiovascular. And these are the premises essentially to take action. But before we can take action, we have to define, and that's what we did, our policy. Just let me remind you what a policy is and what it looks like. It's just a statement, essentially. And a statement that is quite rich because it contains and entails vision, mission, principles, values, and also, of course, the clear objectives that we set for ourselves. And this is, as I said here, a broad model for action for improving and reduce the burden of disorders. So essentially is a framework that we give to ourselves, and it takes time and involvement of stakeholders to write a policy statement, a policy document. Without a policy document, we cannot write a plan. And a plan, as in common language, is nothing but a systematic set of actions in which essentially we make sure that all actions are coherent with one another to attain the ultimate goals that are set in the policy itself. Within these actions, we can identify specific interventions. They can be simple, like a drug, prescribing a drug and having one single patient taking it or not. But they may be quite complex. And we have seen, for instance, in the finger trials that complex interventions seem to be more likely to have some benefits in preventing or at least delaying the progress of disease. And these are multimodal interventions, or complex by definition. So interventions work within plans. Now, the next step down is, a synthesis that in essence, policy is what we think, the plan is how we act overall as a community, and what we do are interventions. And just to remind you that it's quite simple, it's already in our heads, it's the way of functioning and reasoning. The importance of a policy is that, as I was saying, it gives us a preamble for all actors to work together coherently. And that's exactly the point I will try to make in my presentation. But the second bit is that it provides also opportunity to link up with other existing policies in health, and not necessarily limited to the health fields, to promote intersectorial collaborations towards the attainment of our own goals and of goals of the other existing policies that may benefit from our own actions. Now, as I said, designing policies is what we have done, and the WHO collaboration, the World Health Organization promoted this global effort to write this document, which of course you can download, and many of you know online, and you may know that the vision must be visionary and very ambitious, and we talk about a world in which dementia is prevented, the people with dementia essentially, and their care essentially have a much lower burden due to this disease because of the several action things that we do, and we promote essentially their rights. So once you look at this vision, you can think about one main goal, and the goal is indeed to reduce this burden, the burden of dementia, and the impact not only on those who are affected and their families, but in general on communities and countries. One of the main reasons why we have a global policy dedicated to one syndrome, one disease as dementia, which is kind of a privilege from the World Health Organization perspective, is really this economic motivation. So the impact that dementia is having on societies as large is also economical very much. And this moved countries from a political point of view to commission the World Health Organization to create this global report. Technically speaking, there are principles, and of course, these principles I share with many other in the Sustainable Development Goals era. It's about human rights, empowering the people, of course, moving and doing things that are evidence-based, and promoting, as I was saying earlier on, multi-sectoral collaborations to realize and and implement the plan itself. There are some commonalities with the SDGs, like universal health coverage, and of course, methods of equity and appropriate attention to prevention, which is of course critically important in the absence of a cure, but also promoting research into cure and care. Now, the plan, which is an articulation, of course, of the actions that we do, all systematic, agree with one another, and synergistic, is articulated across 7 action areas that you can see here down below, and we'll come back to this in a minute. So there is within the policy itself already an indication of how we should be acting in the future. That's the plan part of what we do. Now, we can say from a public health perspective that dementia is a sort of a Cinderella story, because it's been long neglected, not just in the scientific community, but also as physicians. I do remember when I was a medical student, now many years ago, in the neurology department during my residency, that there was not much of an interest in dementia and dementia patients, not only probably the exception was neuropsychological, and a person interested in neuropsychology and specific aspects of cognitive domains, not necessarily memory and other things. But this has changed radically. And from a public health perspective, you may say that it's a Cinderella story, because eventually Cinderella married the prince. So it was quite of a successful story from a public health perspective. But we're left with the challenge of implementation. As for all policies, this is a key challenge once it's written and once you have the document. These are the typical steps of the implementation that we have to think about. And the idea is that probably the one down below at the very bottom, step number 8, is the idea was what we're doing, which is developing tools, specific tools for each of the specific action areas. Now, this is exactly what the WHO is doing in collaboration with many collaborating centers and experts from all around the world. But the first thing is to tackle and to confront ourselves with the major barriers of the implementation of the policy itself, which is raising awareness. And the premises for this, and why is this so important? It's because recent data from all over the world demonstrates that false beliefs, the main one being that dementia is normal part of aging, is highly persistent. And attached to this and closely related to these false beliefs are the notions of stigma and discrimination. Let me just go back to stigma just for a second to tell you that in the dementia case, this stigma is articulated very likely across 3 dimensions. One is the self-stigmatization. The other one is, which consists essentially on the fact that an older person who may think that they have subjective cognitive decline may not seek help or have, resistance in accessing and using services for primarily diagnosis, or to get to know whether they may have dementia, because there is a self-stigmatization idea. And there is a self-stigma for people with dementia, not just with the diagnosis, but with cognitive and probably behavioral symptoms. Then there, of course, there is more classical, the stigma that is associated with the fact that people around a person with dementia, they have prejudices, and that they may even discriminate people on the basis of that disease. But in dementia, there is a 3rd level, which is called core disease stigma, which is with respect to family members and who are, in most cases, as informal caregivers. So this stigma is quite complicated and has several levels, and is, of course, a major barrier to implement a plan that it aims to reduce the burden on both patients, family members, and society. Now, to just give you one number, apparently 62% of healthcare professionals and practitioners still believe that dementia is a normal part of aging. This is a huge barrier to promote anything, not treatment necessarily, but also early detection and diagnosis. And because dementia happens most likely in association with other diseases, with comorbidities, this has a huge impact on our health in general, not just on mental health of dementia itself and dementia care. Okay, these are the premises and the aims of awareness programs is, of course, that we foster a better
Diana was cross with me with non-muting my, but was it very disturbing?
But also that a true and actual reduction of stigma must be attained, so that discrimination, which is, of course, very detrimental, shall not happen, and that the human rights, of course, that are not violated anymore. Now, these, from a public health perspective, also means that awareness programs pave the way for brain health promotion programs, where we promote brain health across the life course. We heard from Muriel that this is very important because there is a lot big evidence on the fact that there are determinants on how we build up our brain from both a structural and functional perspective all across the life course, even before birth. And we know about that. So we have to inform the population that dementia is not something they have to think about only when they, reach mid age or probably late life, but all across their life course. And then thinking about dementia-specific prevention programs and interventions, including probably something that is early or timely detection that informs timely diagnosis, which is linked to protective therapies, which may be mutuated for cardiovascular researches, or like, conducting a Framingham score on a single patient, or check tests to determine whether we can start therapy with statins and other things like this, but of course applied to the domain of dementia. So there's so much to do for public health. Now, looking at the 7 public action areas, let me just come back to what are the tools that have been developed. And these are just examples, because there are very many, and there is a coordination effort from the World Health Organization to make this available and accessible to all. So the first area is really about making dementia a health priority within countries. So now we have a policy that it's global, and we have to make sure that in country and within countries there are equal policies, and there may be standalone policies, or they may be embedded in broader policies, like, I don't know, non-communicable diseases or others. And there is a guide that WHO has developed to inform countries on how to do this in different ways. Then about the awareness and friendliness, well, apart from the survey, there are now a huge amount of resources that WHO is putting together, linking these up with initiatives in aging, with the Helping Aging Society and friendliness, and many other initiatives of this kind. It's important to prove the efficacy and effectiveness, of course, of these interventions. Now, the thing is that
Oui,
WHO
oui, c'est comme mon qui m'a dit, oui, mais maintenant, oui.
guideline
Non, mais j'ai rien fait, c'est juste
putting together the evidence about this.
oui, oui,
I mean, all the evidence is pretty much
les expressions qui sont montrées, mais je fais
used is
mais
fully
bien,
compliant with all other
tous nos
guidelines
mouvements, etc.
of diseases about
La prochaine fois.
so care in primary healthcare level, and particularly in countries with less resources. I think that the MHGAP intervention guide is a very good tool, but there are diagnostic algorithm and algorithm also for care and treatment to some extent that can be used. Chapter 5 is entirely dedicated to caregivers, particularly in the informal caregivers, and the program I support has been commissioned by the WHO and has now been adapted in countries. And of course, there is a surveillance mechanism to determine whether we are making progress in the best way in the implementation of the plan, and whether the plan implementation is attaining the goal that we want and having the impact that we want, that it is the reduction of dementia. This is the Global Dementia Observatory, articulated across many indicators that are, of course, correlated with the targets and the objectives. The final bit is probably the one that interests all of us, our community, the most, and it is about research and how to just set priorities, which is something that we did on behalf and for WHO a couple of years ago. But most importantly is what we do next, so that we have a much more coordinated and harmonized global effort to advance this research. And I'll come to this in a minute, because essentially this is the idea of the existence of a policy, that through its implementation, we have to leverage and think about ways to favor synergies and collaborations. And just not geographic-wise. This initiative, the Brain Fit for Life, is telling us that the main purpose here is that in a small country like Switzerland, it is hard to promote these collaborations. It's hard to understand and know what people are doing at exactly the same time, and how synergies can be promoted to favor efficiency and also the effectiveness of our collective efforts. Of course, we have to avoid duplications, whilst of course encouraging the replications of our findings, and that is intimately related to the optimization of the investments, including funds, of course, and but also in terms of infrastructures and of time. And finally, working within an agreed agenda means that we do all agree that there are priorities in the field, and that we can share these priorities across. Now, we led an exercise for this for the WHO a few years ago. And I think that what's most interesting about this exercise is not that it is transparent, democratic, replicable, because it uses standards of setting research priorities that have been used in many other fields, not just the one of dementia, is the type of criticisms that we received right after having published this in the Lancet Neurology. And that comes from Leon Schneider. And I think his way of criticizing is always, in the end, constructive, even though it may sound a little bit harsh. So is the dementia research priorities a prescription for failure? That's how he sent a letter to the journal and to me about it. But in the end, it was claiming for the need of a paradigm shift. And this notion and topic of paradigm shift is what I would like to touch upon in the second half and last part of my presentation. This is related to what we mean by it. And I think Lon Schneider is really going in the right direction in claiming that probably we have to accept that there are some barriers and problems that research and the way we are proceeding across discipline is, in the past year confronting itself with. So these barriers, I think, necessitate for us to clarify, first of all, what we mean by a paradigm. So if we need to shift paradigm, we have to agree on what it means to have a paradigm. So the paradigm consists essentially, as you know, in sharing assumptions. And these assumptions prove to be okay and to be solid and robust because there are several examples of problems or better questions that could be addressed and questions that were answered through research on the basis of those assumptions. Those assumptions have been integrated with new assumptions, but although these were coherent, and any system of assumptions, of course, may be further integrated, may or may not be complete, of course, but they have not been questioned much in the past years. Now, but having the same paradigm and approaching a broad discipline and field with the same paradigm means also to share our direction in terms of where we're going. And that may not be in terms of specific goals or aims for one piece of research at a time, but one direction in scientific terms means essentially to share what questions and priorities, but specific questions are reasonable, are acceptable. So this gives us a dimension of constraint that any paradigm gives to a field of research. But within this paradigm, of course, there are methodologies and methods and procedures and also techniques that are pertinent and others that are not. So this is another potential limitation that working within the framework and the boundaries of a paradigm may impose on all of us as a community. So taking a step back about, okay, can we shake this to attain this shift in the paradigm itself? Let me just remind you the easiest simplification of what we mean by the scientific method. So we go from observation to make predictions, stating our hypothesis, we conduct our experiments or any study designs, we do appraise not just the results of our own study, but the results of many studies and try to, of course, synthesize the results. And we shape little by little better theory or theories. And these theories should be good enough to make better predictions over time. All of this, there's a blank spot there, is under some shared assumptions. So this is the core of the scientific method, but all of this resides on the idea that we all agree on these assumptions that are in many cases implicit, and that's fine. That's absolutely fine. What I just would like to highlight here is that this process is best defined as normal science, which is what we do technically. Now, have we had advancements in thinking about, approaching these normal science dimension in a much more multidisciplinary approach? I think that one potential contribution came in the past few years from Thomas Paus, who suggested that population neuroscience is a discipline that is primarily concerned with something that also Muriel mentioned earlier on, which is, considering the importance and relevance of a life course approach to understanding neurodegenerative disorders of late life. So how do we build in the first place and maintain throughout life brain health? And we suggested with Mary Ganguly and other epidemiologists that you know in a paper that we published a couple of years ago, that in the end, probably dementia epidemiology may be rebranded as population neuroscience, because what we promote and what we see and would like to see to happen, as Muriel fantastically demonstrated to us, is that we can conduct new era population-based studies, cohort studies, large enough, inclusive, with no response bias, where essentially we're able to use measurements that have been confined and limited to the clinical settings and research clinical settings. So epidemiology, neuroscience of all sorts, and omics can all be blended into one unique discipline. That's the idea of the so-called representative brain and the findings that we can have and generalize in to the general population. Okay, so going back to the call that Lon Schneider made to us, we need this paradigm shift. And indeed, he's not the only one. I mean, of course, anything that Vladimir Draganski can teach to us from his perspective, from the vascular, of course, experience that he accumulated over years would be beneficial. However, I must say that this position paper that he wrote recently is not exactly informative in terms of how and what to do to attain this paradigm shift. So what I did, I went back to the theory of paradigm shifts, and therefore I stepped into the dangerous field of, well, I should say history of science rather than philosophy of science with Thomas Kuhn, Milia paper, book, Structure of Scientific Revolutions. So this is the cycle, Kuhn cycle as it's called. And I just would like to highlight the fact that we do normal science, and that occupies not just every day of our lives, but most likely all our lives. So a cycle, it may take many, many centuries or some time to conclude. We do this normal science and we know how complicated and complex and how amazing the advancements can be by doing normal science. However, at some point, there is a collective recognition that the model drifts, and therefore there's a proper crisis, and that's when revolutions happen. And this is all based just on the historical analysis in many fields, and not just limited to medicine, of course, but science in general. So how do paradigms change in Kuhn's perspective? You may know this, but the idea is that because progress is not, in fact, development by accumulation, as Kuhn call it, is not linear, essentially, a shift is not logical. And a shift in the paradigm, it cannot be attained through from within the normal science, because we have to change the assumptions. And can we change assumptions from inside normal science? Well, to some extent. So inspiration is probably crucial. So let me give you some examples of what we may mean by inspiration. Well, by reverting back to the basis of our literature in Western society, at least, well, as you all know, the dead in the classical mythology are forgetful. And they have been represented like this, and it's been discussed long why in ancient Greek there was this idea that it was not just necessary to cross the Lete river to lose all your memories before you could, restart your life next. But it's also because probably there is a transposition of something that was observed, and they may have known much more. And if we can get inspiration also on the philosophical approaches from ancient Greek, we can think that in the famous School of Athens, there is a representation of how important it is to have a highly and very comprehensive multidisciplinary group of people and community to be able to essentially, do Plato's gestures toward the sky with the idea that there are absolute and universal principles, and Aristotle's empirical hand towards the ground that says to us, yes, of course, but there are things that need to be done and measures that need to be taken to see how things look like. And as Muriel already said, and I'm very glad that she did it, inspiration can and should come more and more from participatory action research. But that depends heavily, particularly in the dementia field, on our capacity of empower, our ability to empower people with dementia, so patients, but also their family members and community members at large, not just to participate in research, but as Muriel was suggesting, in designing research in the first place. And even another step backward would be to involve people proactively and to let them able to contribute also to conceiving questions that are pertinent and relevant. And that would be a completely view change also for us. So in conclusion, we have a historic opportunity as a community, because having a policy that's global from the World Health Organization, it's been approved from a political level and voted by 182 country members, means that we have a framework for action and a preamble that we can also approach other disciplines and other policies to implement it in a more efficient way. So we can attain the goal of reducing the global burden of dementia, which would be already a lot and can be attained first and foremost by reducing the occurrence of dementia in the first place. So there's so much to do in terms of promotion and prevention, as we have seen But of course, reducing the burden means also that we have to improve what we do in terms of treatment, but care in many levels and taking care, of course, of the people around them. But the real challenge and its historic opportunity is that probably we have to accept that this is a time where our assumptions may have to start being questioned, even though this is very difficult from within, as I just said. And so we just have to accept that probably we have to question ourselves as well, not just our assumptions. So we have an historic opportunity to contribute to a paradigm shift for how dreadful and terrifying that might sound for a scientific community, but that it might probably be the case, because there are, as we know, a lot of dead ends in dementia research, and no matter how hard we try, these dead ends seems to remain still dead ends. We dig deep into these dead ends. That's my final message. And I think, again, stealing something from philosophy of science, I just think that my last message is probably it's time for a collective, comprehensive, global discussion about the methodology of our scientific research programs. Thank you very much.
Thank you, Emiliano. Thank you very much. Big apologizes to presenters that I disturb with my occasional noises, because I was not aware that my micro is on. It was nothing indiscreet, but nevertheless, well, we learned something. I describe myself as a walk in digital technologies, but obviously not. All right. Coming back then to Emiliano's presentation, I was looking if there are any questions. I'm looking at some chats and so on. I don't see any burning questions, but Emiliano, I have one question. What do you think? I mean, you are very strong on this policy side. Again, also to us, I'm a little bit of this impatient nature of clinicians. What do you think is the timeline until all this comes into place in reality? And reality, I mean, really doctors seeing patients with dementia and so on. I mean, of course, also Mireille said this is not a quick process. We have to consider so many details that you beautifully described. What's your timeline? How do you see everything developing?
I mean, of course, also Mireille said this is not...
Okay, wow, this is really a challenge because your voice came in twice with a delay. So I hope that I got the question right. I think that, but first of all, let me just remind to you that the policy also sets a time frame, and it says by 2025 to attain the goals of the policy itself. So not for us as a community. I think that we have a challenge that is imposed to us by the demographical changes. So this is a ticking clock. We are confronted with the fact that probably the epidemic of dementia, as we have called it in the past few years, would be much more impactful than the epidemic of COVID, and because it's a completely different one and it's much more silent. And it does impact at all levels of societies. As a scientific community, I think that the timeline is very unpredictable to predict, because we will learn about the importance of the exponential growth when we were discussing COVID pandemic, and that has also positives. Sometimes progress happens at exponential velocity. So we may even be very optimistic that something will happen soon that will essentially translate into a shift of gear in our field.
Let me just quickly check if there is something new there. But then I have also a second question, because we are very privileged here living in a high income country, but at least looking at the worldwide epidemiology, if we are still in the focus of dementia, it's much more the low and middle income countries, which should be actually more affected by this, as you said, epidemic of dementia, rising numbers in terms of incidence, which are rather stable here in the high income countries. Where do you think should also Europe look after?
Yeah, I think this is a very good point, and we have to be cognizant of the fact that we may have to approach dementia differently, exactly because of these trends. So it may be important that we understand that change in the awareness, acceptance of dementia in Western countries would translate in increased help seeking. And therefore, you know, we still count that 50% of people with dementia in Europe do not receive a diagnosis before they die. Even though the absolute numbers, the prevalence of dementia may not change in the coming 20, 50 years, what may change very likely is that everybody will not just want to have a diagnosis, but they would want to have a health care that is appropriate for dementia. And that can be a claim and request. A completely different situation, of course, should be considered in developing countries, particularly the middle income ones that are most populous, and they may have inner resources that, you know, the health systems are not designed for chronic diseases. And there probably there's the opportunity to explain and to link up dementia to other cardiovascular and non-communicable diseases and benefit for promotion and prevention programs, and also integrated care with other non-communicable diseases.
Thank you very much, Emiliano. Our time is unfortunately up. I'll rush again to present the next speaker. I'll switch on my microphones. I can apologize for the noises and disturbance, and bravo to Emiliano. Speak to you.